First, I'm going to talk about hyponatremia, then hypernatremia. So hyponatremia, several different causes. The most common is a hypotonic caused by either increased ADH secretion, and that increases H2O retention. So you have hyponatremia because you're retaining more water, so your concentration of sodium is lower. That is the most common cause of hyponatremia. You can have hypovolemic, isovolemic, and hypervolemic. Most common being hypovolemic due to loss of a lot of liquids from like diarrhea, vomiting, bleeding, and also diuretic medications. You can have an isovolemic hyponatremia caused by SIADH, polydipsia, a lot of beer, and certain types of cancer. And you can have hypervolemic hyponatremia, which would be caused by something like CHF and cirrhosis and nephrotic syndrome. So the way you would diagnose those, you would take a measured serum osmolarity. You would take an arterial blood gas and look at the sodium concentration in your urine. That would help you diagnose what type of hyponatremia you have. And you'd also want to compare urine osmolarity versus urine specific gravity to help you diagnose. So your treatment is going to be different depending on what causes it. So that's why it's really important to diagnose the cause. If you have hypovolemic, the treatment is going to be normal saline, sodium chloride, and if it's severe, you would use 3% sodium chloride. If you have isotonic, you would treat with just water retention because the most common cause of isotonic hyponatremia would be polydipsia. So you would want them to decrease water intake. If it's a severe case of isotonic hyponatremia, you would treat with tolvaptan, a drug, or 3% NaCl. If you have hypervolemic hyponatremia, you can treat with loop diuretics, and if it's severe, you would treat with tolvaptan. So you have hypo, you would start with sodium, and severe is 3%. And then you have iso in the middle with tolvaptan or 3%. And then the hyper on the bottom, treat with tolvaptan. So iso is kind of like a combination in the middle of the two. Could be either or. And iso is not very common. So in order to do your dose calculation of how fast your rate of infiltration is going to be of these medications, you're going to take the sodium deficit times the volume of distribution. And you can simplify that equation by using the patient's ideal weight. But the normal rate is going to be about 0.25 to 0.5 per liter per hour, and a max rate of 6 to 12 per hour or per day. You want to do a very slow infusion, and that's to prevent an osmotic demyelination syndrome. And one other thing to note about this, if you have acute hyponatremia, you can treat with 100 milliliters of 3% sodium chloride 3 times every 20 minutes, and that's for very emergent situations. So moving on to hypernatremia.